Good morning, everybody. At the outset, my sincere thanks to my co-authors and all the attendees who have attended for this course on SLET. So, my course is on autologous SLET, that is the hope in the horizon. We all know that the stem cells, its expansion and transplantation to treat a variety of ocular surface disorders is one of the most remarkable achievements in modern stem cell biology. And these cells consist of about 0.5 to 10% of the total cell population and can be found in the skeletal muscles, skin, intestine, and eye. These are the cells these are specialized undifferentiated cells having self-renewing properties, capable of indefinite proliferation and responsible for cellular replacement and regeneration. These limbal stem cells is found in the palisades of foot, and these are the poorly differentiated cells, having primitive cytoplasm and long shelf cycle duration. It maintains normal corneal epithelium and prevents conjunctivalization of the cornea. And the ocular surface damage following chemical burn or thermal burn results from limbal ischemia and then subsequent loss of stem cells, which are capable of repopulating the corneal epithelium, and a state of corneal limbal stem cell deficiency occurs if the number of limbal epithelial stem cells are getting depleted below a critical level and by trauma or by disease. And this successful limbal stem cell transplantation can achieve rapid surface healing with stable ocular surface, regression of the corneal vascularizations. There will be no more recurrent corneal erosions or persistent epithelial defects. And then restoration of the smooth, optically improved ocular surface, resulting in improved visual acuity and probably increased success for subsequent keratoplasty. So current treatments are that for unilateral cases, CLAW, CLET, SLET, and for bilateral cases, limb-related CLAL or keratolimbal allograft, allogenic SLET, CLET, or COMET or SOMET. So in this course, Dr. Sharma, he will be talking on the preoperative evaluation and patient selection for SLET. I will be talking on the classical way for doing SLET and its modification. Dr. Vikas Mittal, everybody knows that he is the most authoritative next to Dr. Sangwan about SLET, and he will be talking on the different types and complications of SLET and their management. And then Dr. Swapnil, he is also one of the authorities from LVP. He will be talking on this limbal stem cell deficiency with simleferon, how to prevent recurrence. And then we have ample time for questions and discussions. So now I request all the speakers to be in the dais. Dr. Sharma, Dr. Vikas, and Dr. Swapnil. Please be in the dais, bhai. So first presentation is by Dr. Sharma. He will be talking on this preoperative evaluation and patient selection for SLET. Over to you, Dr. Sharma.
अभी तो दिया देखिए नीचे ही बैठते हैं ना सुनने के लिए कोई चाहिए Good morning, everybody. I would like to thank Dr. Tuhin Chaudhary for making me part of this very important instruction course on limbal stem cell deficiency and management. I will be dealing with the preoperative evaluation of patient selection for simple limbal epithelial transplantation. We are all aware of the stem cell properties, and they have like undifferentiated proliferating cells and present in the self-renewal tissues, and they have long-lived, long cycle time, and they have capacity to divide asymmetrically. Some of the historical points: in 1971, limbal stem cell resides in palisades of Vogt. This was discovered. In 1983, they proposed the hypothesis of niche hypothesis, which is very important, and this is basically the basic of all the limbal stem cell deficiency disorders and its management. And then in 1986, the limbal epithelial was deficient in expression of K3. 2005, Du et al. Reported the presence of limbal epithelial crypts and proposed that they also harbor the limbal stem cells. And this hypothesis XYZ was introduced, and this explains the ocular surface homeostasis basically. One term for those who are newer, I would like to introduce is conjunctival transdifferentiation of the ocular surface. Now, this term was introduced with the concept that after chemical injury, if you make the ocular surface avascular, the conjunctival epithelial cells, they transform into the corneal epithelial cells. And later on, it was proved that it's not true, and then this hypothesis was discarded. Limbal niche is the most important structure because this harbors the limbal stem cells, and this also provides a microenvironment which is essential for the survival of the limbal epithelial cells. And the management strategies also, they are based on this limbal stem cell niche that you have to take care of, and you have to transplant limbal niche if you want to transplant a limbal epithelial cell for longer periods. Coming to the etiology, we have two etiology groups. One is the acquired one, and in acquired we have immune disorders, Stevens-Johnson syndrome, toxic epidermal necrosis, atopic, mucous membrane pemphigoid, and chronic graft versus host disease. Now, this will be taken, I think, by Dr. Swapnil Walekar in later. Of the non-immune related conditions, we have several conditions, but the most important one which we all deal is, and which is threatening, is chemical or the thermal burns basically. And this is one of the most devastating one. And in ophthalmic literature, you used to say that if after central artery occlusion, if there is any other emergency next to it, it's the chemical or the thermal injury, because you need urgent management in the form of lavage so that you decrease the contact time of the damaging agent. Now, this group of the disorders, congenital one, we have several disorders in this group like congenital aniridia, xeroderma pigmentosa, dyskeratosis. But I think most of the times we have, most important one is the AAK. And this is rare, but when we meet, we have to treat this condition. That is congenital aniridia. Iatrogenic stem cell deficiency is an important group, and we all treat our patients, and we should make all efforts to avoid iatrogenic deficiency. We can have it following contact lens wear, we can have following mitomycin C, and limbal stem cell deficiency after glaucoma surgery, or any multiple surgeries if we have done again in the limbus area, again we can develop this kind of problem. The diagnosis of limbal stem cell deficiency is basically clinical, and in milder cases you can have mild epithelial stripping, persistent or late fluorescent staining of the cornea, recurrent epithelial defects, persistent epithelial defects, vertex keratopathy, epithelial thinning. All these subtle changes in the ocular surface and the cornea, they indicate that we may be having the limbal stem cell deficiency, and we have to specially look for these signs to detect early limbal stem cell deficiency or mild. The moderate or severe severe limbal stem cell deficiency is obvious, and we have the pictures on the other side. We can have pannus, which is progressing, conjunctivalization, corneal vascularization, corneal opacity, symblepharon, pseudotrigium, pyogenic granulomas, or eyelid abnormalities. So that all these are abnormalities, but to find out the subtle changes in the cornea which are suggestive of limbal stem cell deficiency, we should also look carefully limbus, and especially the limbal vessels. They say that like foveal avascular John, you should give importance to the limbal vascular arcade, And if there are changes in that area, this means that there may be some chemical insult. And this is especially important in unilateral chemical injuries when you are going to take some limbal conjunctival tissue for either SLET or for limbal conjunctival autotransplant. So this is important to make sure that the other eye is perfectly normal. It's not has got any insult. Coming to the investigative tools which can be used to detect limbal stem cell deficiency, impression cytology is one of the most simple one, and it can be done with the help of expert pathologists. Impression cytology shows conjunctivalization of the cornea. And if your smear, which is obtained after impression cytology, shows that there are no cells, or mostly the cells which we are seeing are the corneal epithelial cells, this means that it's sure that we are not having limbal stem cell deficiency. On the other hand, if your conjunctival impression cytology shows conjunctival epithelial cells, or mixture of both corneal and conjunctival epithelial cells, this means that the limbal stem cell deficiency is there. Another way of confirming it is histopathology, which we always do after excising the tissue, conjunctivalization of the corneal or conjunctival epithelium, presence of goblet cells, neovascularization, disruption of basement membrane, and inflammatory cell infiltrate. All these are evidences which suggest that the limbal stem cell deficiency is there. Immunohistochemical studies can also be done, and absence of cytokeratin CK3 also indicate the limbal stem cell deficiency. Some of the imaging techniques like confocal microscopy can be used to detect limbal stem cell deficiency. When we do confocal microscopy, there may be absence of palisades of Vogt. Basal cell with distinct nuclei and indistinct borders is another indication. Metaplastic wing cells, basal epithelial cells, and then decreased basal cell density, decreased subbasal nerve density, and in late stages the normal epithelium is replaced by the vascular fibrotic tissue. These are the various these are the pictures at the various stages of limbal stem cell deficiency, and at the various areas like on the cornea, wing layer, basal layer, and subbasal nerves. You can see that as the disease progresses, the basal nerves they are decreased, and finally they are absent. And the other picture shows the wing cell layer and basal cell layer in the limbal area. So in the limbal area, the crypts are like in the normal, it's very clearly visible, but once the limbal cell deficiency, the crypts are not visible at all. Going to the anterior segment optical coherence tomography, this is a basically very rapid and non-contact technique, and this is not dependent upon the operator, whereas for confocal microscopy you need a very expert person who has experience of doing confocal microscopy. This provides instantaneous output and has shown good histopathological correlation, and diagnosis is basically by the epithelial thickness, visualizing palisades and quantifying the stem cells. So you can see A picture is basically the normal one, and in B picture again we are seeing the palisades of Vogt. Whereas in D picture you can see that there is a fluorescing stained and fluorescent pooling area at the limbus. So this area, when we have examined on OCT, this shows that there is a thinning in that area. And again in the limbal area in picture F, we are seeing that the limbus is thinned. This is the area where there was pooling. So anterior segment OCT can also be helpful in supplementing the clinical diagnosis. Coming to the anterior segment optical coherence tomography and angiography in assessing limbal ischemia, this has been done by Dr. Sain and other authors, and this is very important. In fact, Professor V.S. Nirankari also has done anterior segment fluorescein angiography of the cornea, and he has treated corneal vessels with various techniques, submitted his thesis for American Academy. So when we are doing CT angio, and we can see the hairpin loops which are visible. So you can see the yellow arrowheads where you can see the hairpin loop vessels, which are normal ones. And again, you can see the Y-shaped pink arrowheads here. and green arrowheads, again, these are vessels which are normal ones. Whereas if there is a limbal vessels which are damaged, ischemic zones, they are shown in the lower picture with the blue heads basically. This picture is basically in acute chemical injury, but the same can be utilized to detect the limbal stem cell deficiency at a later stages of the chemical injuries. Once we have examined the corneal patient for limbal stem cell deficiency, we need to grade the disease. So we have different grading system, but this one is one which can be used conveniently. Now this patient I want to show, because this patient we treated when there was no concept of amniotic membrane limbal stem cells way back in 1977 or 8. So you can see that this patient had bilateral severe chemical injury, and he has chemical injury over the body also. He was admitted in plastic surgery, and I used to take care of this patient regularly. So one eye, he developed, right eye he developed endophthalmitis because of the periocular infection. The other eye, we were contemplating to save this eye. And in this eye, we have a scleral ulceration, limbal ulceration, and then corneal ulceration. At that time, the concept of tenoplasty and glued-on contact lens was there. So we treated him with that. In fact, in this patient, we directly applied the glue on the limbus, cyanoacrylate glue on the limbus, and then glued-on contact lens. And we could tide over this area, and we could save this eye. And later on, this patient saw 636, and we published it in Cornea. Acute chemical injury needs a very efficient management, and if you treat the patient efficiently in acute stage, we are going to get less severe limbal stem cell deficiency, or limbal stem cell deficiency may not appear at all. I must say here that the extent of limbal ischemia determines the area, extent of limbal stem cell deficiency also. So this area is very important, because the prevention is always better than cure. In severe chemical eye injuries, there is a multi-stage treatment which is required. All these corneal issues should be solved before we take the patient for definitive surgery, like limbal stem cell transplants, of which various techniques my colleagues will be dealing with. One thing I would like to emphasize, that if you have a limbal stem cell deficiency, which is very early, and this is because of the chronic ocular surface inflammatory disease like VKC. If we treat the inflammation, the limbal stem cell deficiency in early stage in these cases is reversible. This is very important, and we should treat these patients. In fact, otherwise also, whenever we have treating the this area, we need to make the ocular surface as far as normal, so that the microenvironment is very good, and the limbal stem cell transplant we are going to transplant, they survive here for longer periods. AMT is the one which can be used in the acute stage as well as later stages. We should not jump onto the limbal stem cell transplant directly. As far as possible, we should rehabilitate with the amniotic membrane. Then simulacron, ocular adnexa, all these problems should be taken care of before taking patient for definitive surgery. We need to take care of the glaucoma also. Sometimes we are treating and we are not looking for glaucoma. We may lose the patient's sight because of glaucoma. This is one area which we used to do initially, like limbal conjunctival auto transplants. In this patient with the severe chemical injury, severe limbal stem cell deficiency, we have done this limbal conjunctival auto transplant. This is known with the various names, even the conjunctival limbal autograft, CLAU. So it's very useful for unilateral. We had to take larger tissue from superior and inferior limbus of the normal eye. But one thing is sure, that we should not consider penetrating keratoplasty without limbal stem cell deficiency. Again, if you have a localized disease, we can combine the two. You can always go for conjunctival limbal transplant along with amniotic membrane. This patient I operated long time back. First we treated the limbal stem cell deficiency. You can see the area. There is a transition area where you can see the conjunctival limbal auto transplant, and we did penetrating graft. Patient did very well, and in fact she came for 10 years for follow-up. After that, I have not seen her. PKP without limbal stem cell deficiency should not be done at all. I like to tell the story of this patient, 42 years old male, bilateral severe limbal stem cell deficiency, and we advise the limbal stem cell deficiency treatment, but patient went for PKP at other center. In addition to that, this is the one area which is going to be dealt by my colleagues. this is one patient where we have done PKP following SLET, and cultured limbal stem cell transplant is a good option, but again, this is very costly and doesn't provide the niche which is very essential. So that is the reason the simple limbal stem cell transplant, which is very simple and convenient to master, and we are talking about the simple limbal epithelial transplant in this eye. I have participated in the pilot project, and we had done 10 to 12 cases of this conjunctival cultivated limbal stem cell transplants. In the end, I would like to say that early and efficient treatment of acute chemical injury may prevent or reduce the severity of limbal stem cell deficiency. Despite various advancements, new imaging techniques and diagnostics of limbal stem cell deficiency remains clinical. Patients with limbal stem cell deficiency due to niche dysfunction and underlying inflammation may reverse with the treatment and control of inflammation. Eyelid adnexia anomalies should be treated before contemplating limbal stem cell treatment. Ocular surface rehabilitation is important to improve the stromal microenvironment, which is necessary for the limbal stem cell survival and should be performed before limbal stem cell transplant. Thank you very much for patient hearing.
Thank you, Dr. Sharma, for this insightful talk. So next, I will be talking about this, how to go for SLET. Okay. देखो तो आ रहा है कि नहीं? Okay, so whenever we are managing any patients about who had this limbal stem cell deficiency following any sort of injuries like ocular, this thermal or chemical injuries, so the first and foremost goal is that we have to go for ocular surface maintenance, and then secondary goal is restoration of the corneal clarity with visual acuity improvement. And to achieve these goals, we must have some surgical plan, which includes this symblepharon correction. If the symblepharon is just very minimal or grade 1 or grade 2, then we can go do this SLET procedure along with the symblepharon correction both together. If it is extensive, then we have to do this symblepharon correction and then deep pharynx reconstruction, and then wait for 6 to 8 weeks and then go for limbal stem cell transplantation. So this is the repetition of the slide. This is this unilateral cases where we have to go for claw or SLET or clate, and for bilateral cases we have to go for this allogenic SLET or clate or comet. So this is the diagram, pictorial diagram. So in claw, so direct conjunctival autografting, we are taking 3 to 4 clock hours from both sides and then putting it directly over the limbal stem cell deficient eye. And in clate, this is that means described by Pellegrini et al. So here we have taken this only 1 clock hour of this limbal stem cells, and then we take it and then expand it on a suitable substrate, and then in the stem cell lab, and then after 12 days we put in the limbal stem cell deficient eye. So these are the patients where I did this claw, but this claw should be, that means we have to take only 3 to 4 clock hours. I personally feel that whenever I took this more, then there is iatrogenic LSCD in the this other healthy eye. So here this is the patient had this thermal injury. So I did this this claw from the other healthy eye, and this is the picture after 1 year, and this is the donor. There is no donor area, there is no limbal cell deficiency. Same way this patient had Suna injury about this partial LSCD about near about 180-degree involvement. So after this SLET, after this claw, it was for 1 year now post-op from other eye. So autologous ex vivo cultivation, that is this clate, and ex vivo cultured limbal epithelial transport with the human amniotic membrane is efficacious in patients with limbal stem cell deficiency, and no difference in success rates and visual outcomes between limbal allograft or autograft with clate. But major advantage of the clate is that we can do this procedure repeatedly, at least 4 to 5 times over this claw, where we can do it only 1 time. But the disadvantage is that you have to get at least 2 weeks for cultivation, need these lab facilities, which is quite expensive. So Sangwan et al. In 2012 to get the novel technique of SLET he developed, and which combines the advantages of both claw and clate. So it is called SLET, and that is a single stage procedure, needs less donor tissue unlike claw, and does not need a stem cell lab like clate. And the multicenter and long-term results concluded that SLET promises to be an easy and effective technique for managing unilateral LSCD following ocular burns. So these are the surgical steps. First, we have to go for preparation of the recipient eye, then take this limbal biopsy, that is the donor limbal stem cell preparation from the other healthy eye, and then distribution of limbal transplants over the amniotic membrane grafting. So this is the picture where I am just doing this preparation in the recipient eye. So 360-degree conjunctival peritomy, that is done 2 to 3 millimeters away from the limbus, and remove the conjunctival planus with his, sometimes you need superficial keratectomy or go for diamond bar polisher. So here all the time you have to use this blunt dissection, that is this, take some blunt instrument and don't go for sharp any instruments. So if the patient had, following chemical injury, if the patient had this amniotic membrane grafting, then you can get a good plane of dissection. Just like in the left side, we can get a plane of dissection, but in the right side, there is no plane of dissection, so we have to go for superficial keratectomy. Then after that, we have to go for hemostasis by either by cautery or by using adrenaline, and then go for amniotic membrane grafting. Put this amniotic membrane over the bare ocular surface and use it, fixed it by using fibrin glue. Then limbal biopsy is from the other healthy eye. You can stain it, or you may not stain it. For the initial stages, those who are beginners, they can stain it to know that which side is epithelium. And then just balloon this superior area by injecting this normal saline, and then go for just very superficial dissection. Either you can use this 15 number blade, or you can use this very blunt crescent. If it is thinner, then the proliferation will be better. Then you preserve it in normal saline in a separate bowl. Then this you have taken this limbal biopsy from the other healthy eye, then you cut into 10 to 12 pieces and then placed over the surface which is already made, and then amniotic membrane graft is already transplanted. Here I am putting this just 2 millimeter away from inside the limbus, and you never try to put it inside in the visual axis. Then a small amount of fibrin glue is dropped over the transplanted tissues to secure them, and wait for 1 minute so that this fibrin glue has polymerized, and then put a bandage contact lens. Or in very small children, we can put another piece of amniotic membrane to secure it in a better way. So this patient had this mild symblepharon, so I put a conformer. And then in small children, you should always put a tarsorrhaphy so that there will be chance of less chance of dislodgement of the graft. So this is the schematic representation. So preparation of the recipient eye, then put this amniotic membrane, and then take this limbal biopsy from the other healthy eye, cut into 10 to 12 pieces, then put it over the amniotic membrane transplant eye, and then put a BCL, or you can put a second piece of amniotic membrane. So this is my patient. I am not going this in details. This is a 5-year-old girl who had Lyme injury 9 months ago, and so after preparing the this bed, then I put this amniotic membrane, and then took this limbal tissue from other healthy eye, and then cut into 10 to 12 pieces, and then distributed over the recipient area. Then put another piece of amniotic membrane, and here I put a pastring circumferential suture using tenonylon. So then I put a bandage contact lens along with conformer, and then did a tarsorrhaphy. So this is the picture just after 2 weeks, and this is the picture after 6 weeks. The vision improved from PLPR to 6/60, and after 1 year, patient got 636, and the vision is decreased because of amblyopia. And this is the lumbar donor area. Now, LSCD with significant Limbal, that will be discussed by Dr. Supnil, so I am skipping it. And the postoperative care is that you have to give topical antibiotics till the defects heal. Topical corticosteroids like predacetate 1%, 6 to 8 times. And then it should be tapered gradually. TS substitutes, that is CMC 0.5%, topical cycloplegics initially for 2 weeks. Oral immunosuppressants for allogenic SLET, that should be given for at least 1 year or sometimes lifelong. And these patients need close follow-up till 6 to 8 weeks, then after monthly, then thereafter after monthly till 1 year, and then you can see whether there is any complication or not, anything like that. Now the big question is that does SLET work really? So definitions of success broadly relate to reversal of the features of the ocular surface for failure, and really it works. And autologous simple limbal epithelial transplantations for unilateral limbal symptom deficiency cases, the multicenter results show that the overall success rate is about 85.7%, which remains above 80% of the final follow-up. This is similar to or better than most published results of CLAW or CLET. So to conclude, autologous limbal stem cell transplantation is the treatment of choice in that unilateral, total or partial LSCD. There is no need for allogenic procedure in this condition. And SLET over CLET is the preferred surgical technique, not only because it is efficacious, but also because of its offers many other advantages like being single stage procedure, more affordable and technically feasible in a research limited setting. Now, I'm inviting Dr. Mittal. He will be talking about these different types of SLETs and its complications. And if you have any questions, we'll take the questions after all the speakers finishes their talk.
Thank you so much. Thank you, Tuinda, for arranging this excellent course and giving me an opportunity. And thank you all of you who for coming early in the morning and encouraging us to talk about the SLET. So, can I have my slides, please? Okay, fine. So by now you know something about pre-operative workup of SLET, and Dr. Tuhin has already told you how we do this SLET. So what I'm going to do is I'm going to take you through a set of few cases, and then I'll tell you that what all we learned on the way and how various challenges come over and how do you deal with them. So it's where I come from, Ambala. It's just 3.5 drive from this place. As I said, I'm going to show you few cases under these 5 headings. So it all started with this boy. This was, he was I think 2 years old when he had come to us with tuna injury, very bad chemical burn. We did, multiple surgeries in the acute phase, as Dr. Ashok Sharma was mentioning, and this is what we left with, total limbal stem cell deficiency. And this was, I think, around 15 years back. So I told him to go to Hyderabad and get a CLET done, but the patient was not willing and it was very difficult for him at that time. So at that time I was thinking, what else I can do? Can I create a stem cell lab in Ambala or do something like that? And at that time in the faculty launch at LVPI Hyderabad, I had a discussion with Dr. Sangwan where he told me that this is a surgery, a new surgery he's doing, which he called SLET later. He compared it with a test tube baby or a normal pregnancy. Normal pregnancy means a SLET, and test tube baby means CLET. So I was very excited. I came back and did the surgery for this boy, and you can see the results were marvelous. I was amazed and I was totally mesmerized, and these were similar to what we used to see with CLET when I was doing my workshop fellowship at LVPI. And we got very much encouraged, and later on we even compiled a series on pediatric SLET. We also published on how actually SLET works, because from individual explant these cells come and they coalesce and ensure that the epithelium on the cornea is a corneal phenotype. We were part of this multi-center SLET study which Dr. Tuhin was mentioning you, where we found that the success rate was 83%. So far we have done more than 100 cases, and because the learning curve is very low in this particular. In case you are a cornea surgeon, you can learn it very well. This is a case from one of my fellow who passed out and did her first SLET in first year of her post fellowship. So because it has minimum learning curves, because a single stage inexpensive, that's why the surgery per se is getting accepted world over. So the first learning that we had during our journey. So this was a boy who had a firecracker burn. You can see he presented to us within 5 hours, and this is, you can see, 360-degree limbal ischemia, epithelial ischemia, so bad. And these were the surgeries which were done in the acute phase. And once the idea was to save the globe somehow so that it doesn't get melt, and this is what we were left with. So this is a success, because the acute chemical burn, that kind of eye otherwise would have melted away, but we could save it, and at least there is epithelium on the surface. So at this juncture, we thought that now we have to go ahead and see how best the patient can see. We cannot do a cornea transplant straight away. We have to ensure the surface is good, and the epithelium on the cornea is of corneal phenotype, the transparent epithelium. For that, we decided to do a SLET, and we did a SLET for this boy, and you can see the cornea is slightly becoming better. We can actually see there is a cornea down there, but what we saw was there was a recurrence of SLET. As you can see here, on 12 o'clock there was a recurrence, and there was a symblepharon here. And if you see the preoperative picture, you can see it is in the same area where we saw recurrence of limbal stem cell deficiency. So the reason at that time, then I talked to Dr. Sangwan and said what best we can do. Maybe we should do a repeat SLET. But what we understood was, maybe in that particular area, in this area, the conjunctiva is damaged. So palpebral as well as bulbar conjunctiva is not there. That's why it got stuck. So for that, we have to replace the conjunctiva. So that's what, we decided to do. Along with the repeat SLET, we did a CAG, or conjunctival autograph. And you can see after that, it got really better. And 5 months, 6 months, absolutely good. The epithelium on this is of corneal phenotype, and there was no recurrence of this particular limbal stem cell deficiency even after 10 years. And once this thing was done, we went ahead and did a penetrating keratoplasty, and boy is doing very well. Even now, 10 years down the lane, he's close to 618 vision at the moment. So the recurrence of this focal limbal stem cell deficiency, what we realized that we are replacing with SLET, we are replacing the corneal epithelium, but for conjunctiva we'll have to replace a conjunctiva. So wherever the conjunctiva is damaged, you'll have to replace a conjunctiva, and that's what, as you can see, when we did a repeat SLET, we ensured that we do a CAG as well. This time, suppose today when we see a patient like this which have a, here there's a symblepharon, we go ahead and do a CAG along with SLET. This is a very short video. So this is, although Swapnil is going to take in very detail about this. So this is what we are doing, ensuring that whole pannus goes off from the surface, and this is the area from where we'll take CAG as well as dissection for the limbal biopsy. I generally use 15 number blade, and then the CAG is cut into various spaces wherever you want to ensure that there is symblepharon. You place the conjunctiva over there, and on the center we place this SLET lenticules after chopping into multiple pieces. So you can see I'm in the 3 quadrants. I'm using that conjunctival autograft, and then placing an amniotic membrane, and over amniotic membrane these SLET tentacules, and these patients, they do generally very well. As you can see, this is a patient now, no recurrence of those. So we understood that why this recurrence is happening. It's because we are not replacing the conjunctiva, and that's why now with symblepharon we replace the conjunctiva as well. There was another learning. The same boy, the first patient, when I was doing a dissection, and if you see the donor side, you can see there's a partial limbal stem cell deficiency on the donor side. So the learning was, because it was a beginning, maybe the dissection that we were doing was slightly deeper. So if you are only superficial, then you don't see donor like that, right? And if you want to take a limbal stem cell again, maybe after 6 months, 10 months, you need to leave at least 2 quadrants from the previous donor site. So later on, when we learned that, you can see this is the donor site of our next other patients. You can see, you can hardly make out where you had taken that biopsy from. So the trick here was to ensure that you stay as superficial as possible. So we generally don't use crescent knife. We use 15 number blade, the blunt side of that, so that you stay only in the superficial plane. Next case. So this was a patient, very elderly, very fragile patient who had come with this. You know that this is an OSSN, and the plan was to remove this, do a surgical intervention and do excisional biopsy. When I was discussing with my plastic colleague, he said that, see, we'll have to do at least 3 millimeter extended excision. So what will happen is we are going to remove the whole limbus. So I thought that maybe the thought process is, suppose you remove the whole limbus, there is going to be limbal stem cell deficiency. There's no doubt about that. So how about doing a primary SLET along with that? So we discussed, and we thought that yes, we can do, because it was a very elderly, fragile patient coming, taking the patient again for SLET will be challenging. And this is what we did. After removing that the whole cancer mass, we placed an amniotic membrane and then placed this SLET lenticules. And you can see the individual epithelium coming from individual explant and then coalescing over it, and the patient did extremely well. So you can see, and then he had a follow-up for 4-5 years, and there was no recurrence at all. After that, there are many publications, close to half a dozen publications, on where we are doing some surgery and there is possibility of limbal stem cell deficiency. You can do a primary SLET as well. Another patient. This was an ophthalmology resident, and in the winters, she was trying to squeeze in a cosmetic cream, and suddenly that whole cream went into her eyes, and she developed a total limbal stem cell deficiency after acute phase was taken care of. So we said it's okay, no problem. By that time we were quite confident. We said we'll go ahead and do a SLET for you. We did a SLET, and on 3rd day post SLET, this was the picture, brown. So I was terrified. I said, oh my God, it is an infection, and this is like Dementitious fungus or what it is. I said, okay, I'll take a scrapings right away, and did a scrapings. When I tried to touch for scrapings, it was actually blood collecting underside the amniotic membrane. The moment I made a nick, the whole thing came out, and this was a blood over there which got collected. And then later on there was a difficulty. We had to do an amniotic membrane again. The epithelialization took some time, but ultimately it went fine. But I'm just telling you that this can also happen with the amniotic membrane. And then there was another patient. You can see the simple total limbal cell deficiency, and when we peeled off the pannus, the underlying cornea was clear. We placed an amniotic membrane, then SLET pieces. Patient did very well, but you can see the haze continued for 3 months, even for a year. And then at that time we didn't know how to deal with them. We had done a FALK. Patient did very well, but this haze sometimes does remain for longer period of time. And look at this patient, this picture. So this has undergone a partial limbal stem deficiency and AMG and SLET pieces. This lifting up, the edges are getting lifted up, and sometimes you see this curling. So this amniotic membrane starts retracting. So suppose you have a explants over it, and this amniotic membrane starts getting dislodged. There's a serious chances that you may jeopardize these explants. So these are the problems. So I was doing a debate a couple of years back where I was talking about SLET, another person was talking about CLET, and the criticism for SLET was that in SLET you get haze, and the haze is primarily because of amniotic membrane. So and sometimes you see patient like that. So when you are removing the pannus, you see the underlying cornea is absolutely clear. So at that time I thought maybe there is a Bowman layer, right? So maybe we can use that Bowman layer as a basement membrane for these explants, so that over that only the epithelium can grow. So do we really need an amniotic membrane? So, and this was a patient who had a partial limbal stem cell deficiency. Here, after removing the pannus, what we did was, without placing an amniotic membrane, we placed those explants straight away on the surface, and patient did extremely well. There was no haze, nothing. So we got, encouraged. And this was a patient who had undergone post OSSN. He had undergone surgeries, and he had a recurrent epithelial erosions. And this was a total limbal stem cell deficiency. Here again, we did a SLET without AMG. And you can see crystal clear cornea, 20/20 vision. There's no haze at all. Can we do a SLET without MG in these kind of patients who have a very severe kind of limbal stem cell deficiency? Let's have a look. So this was a patient who had a history of chemical burn, really bad symptoms. You can see the OCT image, and the plan was to go ahead and do a SLET without AMG. And first, of course, you cannot even place cannot place even a speculum. So you have to cut that symblepharon, do a 360-degree conjunctival peritomy, ensure the whole pannus goes out. And you can see this. So I'll take it ahead. So the whole pannus dissection is very important. Then I'm taking a CAG plus SLET biopsy. I'm using the blunt side of the 15 number blade. As I said, this is for CAG, and this is that strip, the limbal biopsy, which will be used for. So first what we are doing is doing a CAG. I'm suturing that conjunctival autograft, and you can see this cornea is pretty clear. So the Bowman layer is there. Looks like that it is smooth. It's not rough. So we thought that maybe we can place these explants exactly after securing the CAG. We just place this explant straight away on the cornea, on the bare cornea. We didn't use any amniotic membrane. And you can see the patient, 6 months post-op, 618. The patient is 6'9" and doing very well. So we had recently published this series on where we have not used. So in the cases where the underlying cornea is smooth, you can straight away place your explants. Only where it's very ragged or irregular, there only you need a amniotic membrane. And there are different ways of doing it. People are using 2 layer of amniotic membrane. People are using even straight away explants over that amniotic membrane. And recently somebody didn't have an access for a glue. So what he did was made some punctures in the cornea and in the stromal, and there he just shoved in those explants, and that did very well. So we need to keep thinking. So my last set of patient is this lady who was living along with her husband as a blind couple for the last 30 years. So her husband had an optic atrophy, and when they came to us, I saw there was a total limbal stem cell deficiency, hand motion vision, and she said that nothing can be done. I said, no, this is a wet surface. We can do a SLET for you. But then this was a bilateral. So that I said, okay, fine. We can go ahead and take a live-related donor and do a AIOS2025-IC210. For that, you'll need to use immunosuppression, and we use immunosuppression in terms of cyclosporine. And look at this picture. From hand motion, she became 6'12". They were living like a blind couple, and she's managing the whole house, extremely happy. And you know what? Her brother was not there. Her sister refused to give her, tissues. Who volunteered to donate the stem cell for her eyes was her 8-year-old daughter. When I was talking to her, she immediately said, no, I'll do for my mother. And we took the tissue from her, and she's doing extremely well. Sometimes if you don't have a live-related donor, specifically in acute chemical burn, there is another good thing is that you can use a cadaveric SLET, and this helps. This Geeta Iyer has published this very good paper, and where in the acute burn, to ensure that epithelialization is quick, you can use a cadaveric SLET as well. My last case is this boy, Sanjay. He's very close to my heart, and whenever he comes in OPD, I spend a lot of time, keep on talking. He's in 10th now, and you know why he's very close to my heart is because he's the same boy where I had done a first SLET, in 2010, and now he's close to 15 years, doing very well. Those SLET last really long. So we keep thinking, the CAG we learned you can do it in OSSN. We learned how you can do without AMG, and AIOS2025-IC210 only with immunosuppression. Before I close, I had got, when we were doing this SLET course, so somebody from the audience called me up after 4-5 days, said, Vikas, you had shown me those SLET videos. I want to do a SLET in one of my patients. Can you please send those videos? I said, what is the problem? Just tell me. He said, no, there's exactly the picture looks like the way you had shown. So please send me the video. I'm sure that I can do it. I said, no, please send me the photographs first. And he sent me this photograph. You can see this. Dry keratinized surface. This is contraindication for SLET. Must not do a SLET for these kind of patients which are dry keratinized surface, or the Steven-Johnson syndromes, ocular cicatricial pemphigoids. So these are contraindications. So we need to keep in mind, it's not that it's a magical surgery for every ocular surface disease where you have a wet eyes and it's only the stem cell deficiency. My gratitude to my mentor, Dr. Sangwan, and a wonderful department at LGI Institute. And we have all the videos of SLET we have put in this as a cornea color series in our YouTube channel. You can definitely take a pic and go through it. Thank you so much for your patient listening.
Thank you, Vikas, for an excellent talk. So one thing you should remember that if this corneal surface after just that preparation of the bed, if it is very smooth, then only these limbal transplants can be put directly over the surface. If it is ragged, or if you have done some sort of this diamond bar polishing or anything like that, then these stem cell transplanted stem cells may not proliferate that well. So you have to put AMG. If it is very smooth, then only directly put it. Okay?
No
okay.
No.
Okay, now the next by Dr. Swapnil, he'll be talking how to handle Simpliferon in LSCD with SLET.
Hi. Thank you, Tuhinda, for making me part of this interesting IC on SLET. Most of the points are covered by Dr. Vikas and Dr. Tuhin about how to do SLET. And this is a very specific point which Dr. Vikas has made the point that whenever there is a Simpliferon, we cannot just do get away with SLET. We have to replace the conjunctiva as well. So I'll just share some extra insights into it. So whenever there is a LSCD with Simpliferon, we have to replace the Simpliferon part, the bare sclera, with conjunctiva. What alternatives we can use? We can use either conjunctival autograft from other eye if the eye is not totally damaged, or you can use conjunctival autograft from the same eye. You can use MMG, but make sure that when you are putting the mucous membrane graft on the bulbar surface, make it very thin and stretch it properly, otherwise it will get folded up and bulk up. And this is third point which I am going to show a video about today, and that's all it is going to be about. It's the pannus which covers the cornea. When we have LSCD, the pannus which covers the cornea is also a conjunctival tissue which has a stable epithelium. So essentially, when we deal with LSCD with Simpliferon, we have to replace with some stable epithelium. This was one of the patient with severe LSCD, and I'll not go through the video completely because Dr. Vikas has already shown how we do CAG when we do SLET. So I'll just run through this video. So here we had to do, there was a lot of scarring, so we had to remove the pannus with lot of difficulty. And in such cases, as we discussed, we have to replace this bare sclera with some kind of conjunctiva. So in this particular patient, what we have used is, we have used conjunctiva. So one more point I would like to make it, when you place the conjunctival autograft, like I have placed a conjunctival autograft over here, don't place it over the AMG. Once you cover the cornea with the AMG, and then if you place it over the AMG, sometimes it may not get vascularized and it may get necrosed. So it's always better to cut the AMG in that particular area and then place the conjunctival autograft directly onto the bare sclera and then do the SLET. So I'll just run through the video because he has already shown how to do CAG. This is how this patient did, though there was a lot of scarring. Later on we had to go for DALK. This was another patient. This is a presentation in acute chemical injury, and after AMG the patient presented like this. So after 3 months the surface was nicely healed, and we can see there is a Simpliferon superiorly. So we'll go about how we manage this patient. So again, as we say, it was even difficult to put the speculum in the superior area because there was a huge Simpliferon over there, large Simpliferon. So you start dissecting the pannus. So now, as I said that this pannus is important, this is also a formed conjunctival epithelium. So if you handle it carefully, so you hold it from beneath. If you try to hold it from above, it will form buttonholes, lot of buttonholes. So here right from beginning, the plan was to preserve this pannus rather than taking the conjunctival autograft from other eye. So here I am trying to hold the pannus from beneath so that it won't form any buttonhole or anything. And you can see I have got a nice plane. Now once superiorly, you can see once I have resected the pannus, there is a bare scleral area. See, I am again and again checking that the pannus doesn't have the buttonhole or it is not getting damaged. So this is a very nice stable epithelium which we can always use. And then once you do this, this is the pannus. There are a lot of fibrotic tissue underneath, so you can always trim it like we do it for MMG. So you can just hold it, stretch it on the middle finger and try to take out as much as fibrous tissue as possible without creating a lot of buttonholes. And this now we have created kind of a conjunctival autograft from the same pannus which was covering the surface after chemical injury. And this bare area we covered with the pannus. So this is one method where you can always use the same pannus. So try to, whenever possible, try to conserve that pannus and try to dissect it in a way that it will not be piecemeal. And then here again one modification I did, like Dr. Vikas showed that he tried this or he rather proved that the SLET works only on the clear cornea. These were the initial cases when this was not very clearly established, and even I used to get bothered by these heads And we always used to feel that we have done wonderful job and this cornea is so clear, but now for next 2 to 3 months this haze will remain, and later on it is going to clear up, but it is going to remain like that. So in this particular case, what I did is I removed partly AMG in the center of the cornea where I don't want the haze, so that patient will have at least good vision within a month or so. So around 4 millimeter of the AMG is removed. So at that point, the thought process was that the limbal area is much damaged and it needs some kind of biological cover, and that's why AMG was placed on limbal area. But in the center, the only SLET implants were put, and this is how it was distributed all over the AMG and the cornea itself. And this patient also did very well. So this is around after 5 months, the cornea cleared up very nicely. But right from, you can see 2 weeks patient was seeing very well. So this is one of the method you can use. But obviously the cornea is clear, as Dr. Vikas has already mentioned. You can directly do on the cornea itself. So this is so the take-home point is try to preserve the pannus and use it as a conjunctival autograph whenever there is a symblepharon. And you can also use partial AMG and partial clear cornea for doing SLET. Thank you so much. The message about ocular surface through this IC is you need lot of you need to have a heart of the artist. So it is kind of a science. It meets the art and compassion. So you need to have some compassion to manage these cases, and then only the miracles unfold, like you saw in Dr. Vikas' cases. Thank you so much.
Excellent talk, Dr. Swapnil. So ultimately, we have covered everything, I believe. So if you have still any questions, we have 10 minutes to answer all your questions. Okay, please. You be here. No, not working. This one.
We can hear you.
Okay. Tarsorrhaphy, when you do tarsorrhaphy, in which cases? I do tarsorrhaphy in almost my all cases, because whatever I have found that these limbal transplants from the other healthy eye is very much, that means, important. So my most of my patients are children. They usually rub the eyes, and sometimes there is chance of dislodgement of these transplants. And also in many of the cases there is fornix also got shortened, there is symblepharon formations. So I put a conformer also in some cases and then put a tarsorrhaphy.
Both pediatric and adult.
And these are the suture tarsorrhaphies, so just after 2 weeks you remove it.
Okay, right, sir.
Okay.
And sir, I have one question.
You want to
for
add?
you. In one of the case, as you showed in your slides, also the amniotic membrane got shifted along with those stem cell, limbal stem cell parts. So next day I tried to put the suture, but what is the ideal way of doing it?
So if it, because the explants are very crucial, as Dr. Tuhin said, it's better to put a suture.
Okay.
And that what you can do is you can put a suture on the limbal side, so you can stretch it.
The way
right?
we do it, like
Yes,
after
yes.
chemical engineering.
The patient which I had shown you, so I didn't do anything. I thought that maybe we should do a suture, but somehow the patient said that he didn't want to do it, and patient did well somehow, right? But it is better to do that, just stretch it up and then do it. When you have this typically happens when you have a partial limbal stem cell deficiency,
Right, sir.
or you have half of the cornea has a normal original epithelium, and the half of the one you want
Where
to,
we want to
so
have
there
it.
you have to ensure that you place a good nice sutures.
So is it a good idea to place the suture right at the fur?
In case partial limbal stem cell deficiency, I would say yes. For total, we don't use sutures. We use suture only for whenever we want to do a CAG, right? Like Dr. Swapnil also showed that, because that conjunctival autograph tends to get shifted. So it's better that you secure it on the limbal side, and on the palpebral side you can, or on the pharyngeal side you can definitely put a glue over that.
Sir, I have another question. Like in a typical post-operative period, how often do you stain?
How often do you stain? You don't need to stain. So why that during that paper? So one day, the third or fourth day, that just somehow BCL fell off.
Right.
So I was seeing that, and I saw some different kind of, it was looking very beautiful that on an explant there
those
was
spots,
some
something was
glistening
oozing out.
thing. So I just thought that let's stain it and see. And when I stained, it was a wow thing that You see it, on one explant, half of the epithelium is coming, another more epithelium is coming, some not coming at all. So for compiling for that studies, we did a staining every alternate day, but we don't stain it. We don't need to remove the epithelium, stain and put it back.
Yes,
You don't need
that
it
would
unless
become
you
very
are
messy, yeah.
suspecting something.
Sir, I have a question for you. In one of your slide, you showed the ASOCT picture of limbal stem cells, like that limbal region. Can you just show it to me again, or can you just explain it to me?
Can you repeat the question?
Yes, sir. In one of your slide,
Yeah.
you showed the ASOCT picture of limbal stem cells, like the limbal area and how
Yeah.
it was there. Can you just explain it to me, because I really want to know. I
Yeah.
haven't been using this in practice.
Sir.
Basically, that is the if you do ASOCT, you can see the on the limbus the palisade of Vogt. So once you do the ASOCT and staining before that, you can mark the area that this is the suspicious area, and on ASOCT we can only look for the thickness. So along with if it is a thin area, it is collaborating.
Right.
Yeah, so
Thank
the
you.
idea is that what sir is trying to say is that it is not diagnostic.
Right.
It will give you some
Yeah,
ideas.
it's basically the for all clinical purposes, the diagnosis of limbal stem cell deficiency remains
Clinical
clinical.
only,
Clinical
right.
only.
And for donor area, what we do is we see it on the slit lamp during the OPD itself. I generally say that superior-temporal area, superior area, which is the area of the donor site is going to be. We avoid inferior ones. We take the upper ones only. But most of the time, superior nasal or superior temporal areas are the one where you see a lot of palisades and pigments,
Yeah.
and that is the area
Yeah.
that you take up for your biopsy.
Regarding tarsorrhaphy, we were discussing, if you if you are correcting symblafron, if you are putting like conformer as Dr. Tuhin has shown, in these cases you need to
Definitely,
put the
Definitely. No,
suture.
I was just wondering, like, do it routinely in adult cases also, or just the pediatric cases? Adult also you do it, sir?
For me, suture tarsorrhaphy in all SLET cases.
All
So I
sutures,
don't.
right.
So whenever there's a doubt in my mind for tarsorrhaphy, it's not about SLET for anything. So whenever I doubt that should I do a tarsorrhaphy, the
It's
answer
better
to
to
this
do
is
it.
yes,
Yes.
because it works like magic in many of the cases we
I
all
think
know.
I would like to emphasize through this course that the tarsorrhaphy is one surgery which is very important, and all I think not corneal surgeon, ophthalmologists should know it. Most of the patients who are having herpes zoster, they are having neurotrophic cornea, they are having corneal melts because the tarsorrhaphy was not done when it should have been done. So tarsorrhaphy is one surgery which and simple also. And even if you cannot do the other, you put the suture at least.
Right, sir.
And most of the patients, they feel that their attendants, their family members, they want to pull it. They want to pull it. That what happened? I have spent so much money, and how it happened? We have to see. So put tarsorrhaphy.
Right.
Okay, for all cases.
Great.
Any other questions? Yeah, ma'am, please.
So in LVP, Dr. Vikas, you remember, whenever there used to be extremely severe chemical injuries, and we used to call Dr. Sangwan, तो कुछ क्या करना है समझ में नहीं, he used to say आँख बंद कर दो, tarsorrhaphy कर दो.
True.
So that's how important it is.
Very true. Very true.
Good morning. I want to ask, is the commercially available AMG suitable for SLET or not? Commercially available?
You mean
Yeah.
dry AMG?
Yeah, dry
the
AMG,
one?
that is.
I don't think it is a very good idea.
No.
Yeah.
We should only go for
Wet one.
the
It's better to use the fresh one.
Wet one only.
fresh one.
We had tried dry AMG once, but it is very thick.
Yeah.
Very thick, and you have to reconstitute. You have to put
It keeps
NS,
on
and then
getting off.
No, you can
somehow.
you can use it for other purposes, for non-healing epithelial defects, for other reasons, not for the SLET,
SLET.
not for the
Yes.
SLET.
So another question, how to deal with extensive semblafron and LSCD? So can we go for, in the same setting, we can remove the semblafron, or we can go for step-by-step approach?
So the
In
idea is
360
extensive means, it is,
Both
let's
the
say
lids.
it is covering 270 degrees.
Yes.
So when you take a conjunctival autograph, you don't need a cover from limbus up to the fornix, right?
Okay.
So you can divide that conjunctival autograph into different strips and try to cover at least from limbus up to 2 to 3 millimeter, and try to cover all 270 degrees.
Okay.
Rest of the area you can cover with AMG, but from limbus up to 2 to 3 millimeter, you have to cover with strip of conjunctival autograph. So you can divide in multiple strips and then place it all along the limbus.
Okay. So go for semblafron leads first or the AMG first? sorry, the SLET first or the semifron release?
The symboliform release followed by conjunctal autograph followed by SLET, because
So how many weeks
the
later
conjunctal
will-
autograph will go beneath the AMG, not above the AMG.
She's asking one sitting or two sittings?
or
One
multiple
sitting, one sitting, no problem. Yeah.
In one sitting itself, you can do
Yeah.
everything.
everything? So
Yes.
lead and
Yes,
the
yes.
area and the
Yes.
SLET.
In fact, if you don't do in one sitting, it will recur if
Yes.
you do SLET first. So that is not the option,
Yes.
right?
Thank you, sir.
Last question, one last question.
Dissection that you said we have to stay superficial. matlab, how do we define that? How superficial should we be? What should be the depth?
So what we do is the way we do a conjunctival autograft, you start from 4-5 millimeter behind, pick up only epithelium, means tenon free conjunctiva, straight away keep going in that, and then when you reach the limbus, use blunt size of 50 number blade, and then you keep on dissecting. The end point is when you start seeing a clear cornea.
So you start seeing those pinpoint bleeding points. So that is the end where you just have to stay superficial. But you have to achieve that area where you start seeing those pinpoint bleeding points at the limbus. Thank you so much.
Thank you to all my co-speakers, and then I thank to all the attendees who have come in the morning to attend my course on SLET. Okay, now we'll hand over the session to Dr. Dr. Azad for ROP session. भाई,